present evaluations, which we do often, they're not always as celebratory as this one. And I think we've heard that from everybody who's spoken so far this morning, is there's a real sense of accomplishment. And I won't make it suspenseful. The evaluation very much endorses that view, is that this is a huge foundation to an extremely ambitious program. So what I'm going to do is I'm going to take you through the evaluation process, tell you some of our kind of highlight findings. I'll be doing that through the lens of 6 key deliverables. And you heard Stephanie say before, the program started out with 11 kind of work programs or big objectives. We compiled those into kind of 6 deliverables that some of those assumed those 11. So it's just a slightly different framework. The reason we did that is because we were listening very closely to what everybody was saying and how they understood the program in practice. And for us, that's very much what an evaluation is about, is saying, well, this is what was planned, but now what actually happened and what was people's experience and what do people really say? I imagine many of you, our team spoke to over the course of the 4 years of the evaluation, and thank you very much for that. I know sometimes getting the 4th call for us when you're doing busy clinical work probably wasn't the highlight of your day. What we were really grateful for, and I think what gives this evaluation real meaning, is that people never glossed over things. I don't know how you see your colleagues, but we definitely see them as being extremely critically engaged, very able to assess success and then weaknesses in processes or weaknesses in thinking. So we always felt that there was a very robust engagement with the evaluation from everybody we spoke to, and people really did call it straight, we felt, which is really appreciated. So we look at those 6 key deliverables and what you guys and all of your colleagues said about it, as well as external people to the HSE. Now, primarily we focused on the HSE. And when we talk about stakeholders, which you'll see in a lot of data, what we mean is the over 300 HSE people that we either spoke to or engaged with through surveys. You'll also see in some of it, we managed to get to our end user being parents in this case. We managed to ask them about their experience of certain facets of the work. We also engaged a lot with PHNs and CMOs around their experience of the training program. So these are all the various sources of data. We also asked them about the effects on the system, because when Nurture started, everybody knew that getting this work done wasn't going to be easy, sustaining it even more difficult. And Nuala was just talking about the evidence gap that we have, is that we know what needs to be done, but often systems, and the research often says between 60 to 70% of implementation programs globally fail to address all of their objectives. So everybody came into the program with that experience, and there was a very definite focus on how do we make sure the system is best aligned to support the sustainability of the program. So that was broken down into a number of objectives. We'll also be looking at those and saying, well, did those come to pass? The kind of changes that everybody tried to make in the system to make sure that this was as sustainable as possible. And then we'll be ending very briefly with some kind of highlights from the recommendations. You have those, of course, in your summary report in which you're holding. The evaluation was undertaken by us in partnership with DCU. We're a charity and a social research organisation, and we had the nursing department of DCU supporting the process. So we know that Nurture program was extremely ambitious and far-reaching. And I think throughout there was a small degree of surprise often that came up in the program when people saw just the absolute amount of change that was being forwarded at the same time. What we heard a lot, especially as the program moved on, is that not one of these pieces could really have been set aside, even though at times the sheer amount of work was intimidating for those that were involved. But as the program moved on and people could see those work programs come to fruition, there was definitely feedback. No, we couldn't have left anything else, even though we gave ourselves such an ambitious schedule. We've heard about who the program was led by, and a number of people have talked about the importance of that partnership, which I'll talk about in a moment as being one of the important aspects of the program as well. So in 2014, those partners came together, and all of them had a grounding in this area from various perspectives. With the Catherine Howard Foundation, they led a number of programs and done research, as had CES from an implementation perspective. In the HSE, Best Health for Children provided a real grounding in terms of the thinking that was happening in the HSE and the review of both the successes and the elements of that hadn't come to fruition. really set out the stall for what kind of things could happen over the coming years. So together, everybody developed a logic model, which was supported by CES and really did ground the planning of the program. That took 2 years. So one of the big learnings from a process like this and from implementation science, which I'll be talking about how that's influenced the program, is the sheer amount of time and energy that goes into the planning before any of the actions start to be seen. And that's something that came out a lot from people kind of saying, wow, it feels like we're doing a lot of this. But again, as the program moved on, that narrative changed slightly from one of maybe caution or surprise at the amount of time things were taking to one of saying that was really worth it. It took longer at the beginning, but it has really been worth it, and we would not change a thing. So I think there's a good systemic and structural learning in how the program went about its business. The structures were set up fairly early on, and there was both an oversight group and a steering group. They drew from across the HSE, including primary care and health and wellbeing, as well as outside the HSE, like the Department of Youth and Children, TUSLA, and some community and voluntary representation. One of the things that people talked about as being a real success of the program was this kind of multi-layered accountability. And that meant that people had to hold themselves to their plans, to their timings, to their processes, often due to the ambition of the program, when it was extremely difficult to do so, just because of the sheer amount of work. So these multiple levels really do give the program its structure, and quite a unique and important structure. It was also flexible, so you'll see in 2017 a strategic review group was established, again to deal with a certain event that was happening and the need to move certain aspects of the program on in a slightly different structure. And then, very importantly, we have the 6 implementation teams. So the staff in these teams were selected, and this process in itself took a long time. And often, I'm sure everybody in the room has been involved to some degree in some kind of change program. Often how it happens when we're looking at large state changes is that someone will be asked, send along someone, please. And so if it's a cross-sectoral place, one department sends someone else sends someone. Often the staff will change, and we've probably all experienced what that feels like, is that people aren't briefed, they maybe aren't entirely in with the vision, they're there because they've been asked to. And following the guidance of implementation science, a very different approach was taken in that people were hand-selected for their belief in the vision, their knowledge, their leadership capacity, and also to ensure that there's a real spread across different divisions within the HSC and different geographical regions. So trying to do that across 6 groups is, of course, quite a challenge, but one that the teams really said, well, this made us work, is the fact that we had this difference in representation, the fact that there was a real sense of collegiality from the leadership on these groups. Could I just ask, anybody who was involved in one of these groups or engaged with these groups on any deliverable or advice giving, would you mind raising your hand just for a moment? Raise them real big now. Raise them real big. Okay, so this evaluation, and I think the celebration that really this represents today, is for everybody in the room. There was an enormous amount of people involved, between 7 to 12 on each group, and they met 4 to 6 times per year, as well as doing additional work outside. And that work was often timelined, deadlined, and guided by standards that made it very robust. It wasn't simple work; it was complex and very considered work. And all of that happened in addition, for the great majority of people, in addition to their normal roles. So when we talked to people, we asked a lot of questions as we went along the process in terms of, did you have enough time? And often people were like, well, kind of not really actually, but you know what, I really, really care about this, so I'm going to make the time. So that was something that I'm sure is a theme recurring throughout the HSC and whatever's happening, but that's one that came through very strongly in this, is people really, really believed and were very committed, and it's on the back of that energy and vision that this program was delivered. And I'm going to talk about the outputs as we go along as to what happened. So there was an HSC team that delivered this and was built up first from the program lead, and then bringing on a child health communications manager, there were project managers, and later there was a research and data analyst, as well as in 2018, 9 child health program development officers. So that in itself was a significant progression, ensuring that across the CHO areas there would be dedicated staff to deliver on the strategy. There's one person who isn't mentioned, and I've asked permission because we don't usually, when we stand up, talk about individual people. We talk about the roles. that we do. But consistently, when we talked in interviews, someone's name was mentioned. And the reason that I want to call Brenda McCormick out is that the work that Brenda did as an administrator embodied what people said as to why all of those teams worked. And, obviously, Brenda and Anne worked very closely on this. And I'm going to use the term servant leadership. I'm going to use a term that we use a lot in our leadership training. It's called servant leadership. And what it means is that you're in charge and the buck stops with you. But you do that in a way that supports everybody else in the way they need consistently and in a really deep way. And that's something that people say back to us, is that meetings were done, minutes were done, people were briefed. Every barrier that could be seen in front of people to engage in this was removed. That when consultation was done, the tenacity of recording every comment, of making sure that people were engaged, and so that people's views were recorded and respected through thousands of Excel sheets, that was done. And people said again and again, I felt respected, I felt heard, I felt cared for. When I had a problem, I could come, I was listened to. And for all of the implementation team members that we spoke to, that was a huge and I think often unnoted success as to why this very complex structure worked very well. So what else made the Nurture program different? And we've heard actually from all of the speakers, I think, have covered the majority of these points in the sense that the partnership approach was extremely useful, and the support, the profile, but also the accountability that built in between the various partners, and it stopped slippage, it ensured challenge, there was a diversity of views, and that really strengthened the way that people considered the work program. The matched and leveraged funding, so in total 10 million that was given by Chuck Feeney through the Atlantic Philanthropy, and that was a proportion of the 8 billion that was given out from that fund over I think the 36 years in total. And this was one of the big funds that were really considered as hugely important for laying foundations for future change. So a legacy fund is how it was understood. It was one of the latter grants that was made towards the closure of the fund in 2016. So it was really considered in light of what people have been talking here about creating foundations that would ripple and have change across years and years to come. The implementation science methodology. So implementation science, and I'm sure most of you here are very familiar with the idea, has given us a brief rationale for why it's so vitally important, because most change does not work. And most of us can probably think of, I could ask you to raise your hands, but I won't, because I'm sure everybody would raise their hands if we say, have you ever been part of a change project that didn't last? And it's heartbreaking because we invest so much into these kind of things. So implementation science is a set of approaches and methodologies that CES is extremely well grounded in and a national expert in. And CES really supported the introduction of that to this process. And at the beginning, there was a little frustration at times with having to work in this new way, which at times felt laborious, at times felt overworked. But as the project moved on, people said, yes, this has meaning. I'm so glad we do this. And towards the very end of our third year in the evaluation of asking implementation, people were like, oh no, we're going to do this all the time. And it's great to see that transition with a model like this that is quite challenging. The aspects of that really brought the program to life included the logic model, the implementation planning, which was very, very detailed. Because of course we always have plans when we do projects, but the planning here has a number of methodologies and lenses that are quite unique, and they look at culture and system and communications, the pieces that are often left off normal planning. But when they bring them on, what happens is that you're looking at how do we take the system as a whole? Not just one process or one thing, but how do we look at the whole needs of the system so that staff can be brought along a journey in a supportive way and that things can be sustained into the future. A big part of that as well was the teams themselves, and then the interconnectivity between the teams, which was very complex. And I know, Anne, a lot of your time was spent in just connecting up all the various work streams, a huge amount of work. The Infant Development Fund will exist beyond the life of the project, and again we've heard about CEF and KHF's role in doing that. It'll be a $5 million grant from 2020 that will seek to fund aspects around child health, and that I think is really heartening for the ongoing development of a program like this. A huge element, and Paul raised this, was the engagement of parents and staff in a very, very genuine way. And not at the end when there's a shiny draft, we bring a shiny draft out and say, what do you think of that? And everyone says, yeah, okay, that's fine. But in the beginning, and that's quite hard, because when you do that, an organisation or the people involved have to face a number of fears. The first fear is that you're going to bring something out that's not entirely complete, and people are going to say, that's rubbish, you're terrible. And people have to get used to the idea of co-creation, which is that you're being involved in creating something in real time. So no, you're not seeing a perfect draft. But that means that you have a real chance to influence what that product will look like. And that's the approach that was taken for this, is that there was multiple consultations at multiple points, many to inform the initial planning, to understand the needs of parents and staff, and then following that to either test products as they came out, such as the website or different tools, or to get staff's view on how this would be implemented or what it should look like in an exact way. So imagine the consultation being a funnel. The first there's really broad ideas, and then we come down until we get quite minute consultation that might be a discussion over a word or a phrase. And lots of this was done, up to 8 in 1 year, a minimum of 3 every year over the course of the program. So you can add those up and you're getting 20 consultations, many which have involved over 100 people in a consultation or an engagement. So that made this program very unique, was the continued enforcement that we need to go out, we need to ask, and we need to listen. So the evaluation took 4 years. We did 7 research reports in total. And there's 3 final ones. A summary, a full report, which will be up on the website in a month, and then the final report, which we'll be launching in January to February, which really looks at a lot of the learning. So the how of the program, what was it about this program that did result in successes, and are there learnings that can be taken into other change projects in the HSE or other aligned human services. So let's look at the 6 big deliverables. The first one was the Antenatal Standards. So this was, very early considered an important thing to be developed. And it was done in consultation with the whole sector, and unusually for this one, I think also included private providers. So obviously that brings a lot of difference, a lot of agenda, a lot of different models to the table. And it was starting from scratch. So there was no previous work done on standards within Ireland. Work was done to look at what was happening internationally, and then really a lot of consultation to bring those partners together to decide what that should look like. And that included the HSE National Women and Infants Health Programme and the HSE Nursing and Midwifery Services Director. So there was engagement with the various parts of the HSE. This hasn't been implemented yet. It is on the absolute cusp of it will be rolled out with guidance and other supports. But our stakeholders were very clear. This is extremely important. It's a big foundational document, ensuring that a big theme across nurture all of the time is that wherever you live in Ireland, you're going to get the same high quality supports. And this is obviously very much, very much speaks to that goal. The next one is the mychild.ie. We heard Paul talking about that. It is definitely the most visual product from the Nurture program. It's the one that I think people feel most proud of. And it was the first large-scale mobile first, and I'll talk about that in a minute, website development that was in line with HSE's digital roadmap published in 2017, and really looks at how information should be disseminated online. So first of all, there was a big consultation with parents, and parents said some very clear things. They said, we want online resources, but we want to be communicated with in a very certain way. We want to be communicated with as equals. We would like a friendly tone. We don't want to be spoken down to by experts. And so that was a big challenge, because a lot of traditional information in health services across many countries takes a slightly different tone to that. It is one more of authority, the authority of medical practitioners. There's a lot of obviously complexity in medical services. So this was a challenge. And communications really came into play here in terms of crafting guidance and a structure in which that could be brought to pass. 60 people engaged in drafting information to that, and very closely in line with the communications team. Up to 12 drafts at times of an individual article or piece could be undertaken. So that gives you a sense of the amount of work involved in this. because there were 525 pages of high quality content. So you can imagine the huge amount of work to bring that to a standard which was consistent in terms of wording, accessibility, and that managed that balance between being evidence-based and being acceptable. And that's not always an easy bridge to cross. It attained a reading age of 11 through the Flesch-Kincaid reading assessment. And that's really good. That gives us the same as about the red tops, like the Herald or the Sun or those others. And often when we look at health resources, that's what we're aiming for, is that level of accessibility. So that was a real success. The other thing that it did, that people commented on very well, is the diversity of its messaging. And a lot of thought even to the word like housing, how you say in your house or in your apartment. The way that was expressed was considered so that it didn't exclude homeless people. So there was a very, very detailed level of thinking, how do we communicate so that we can be accessible to everybody who needs this information? You can see there that, I won't read all those numbers, but there's a huge amount of engagement with the public. And of course, that's increasing and will feed in on itself. As people become more aware of it, it will be used more and more. So what did people say? And we talked to over 200, we engaged with over 200 people in a variety of different ways. Some people we watched use the site. We had a survey and we also had interviews with users of the site. So 75% of users would recommend it to others. They felt the site was trustworthy and reliable, straight talking, easy to use, caring, compassionate, and obviously written by health experts who would have been in trouble if they hadn't agreed with that last one, I think. So people really, really appreciated it, and those were all of the ideas that people wanted to hit. That was the goal, is that it appeared like that, and so there was a very high agreement with that. Around 2/3 of PHNs said they'd refer parents to the site, and slightly less than that using it themselves. And the majority of parents felt more knowledgeable and confident after visiting it. And I think that's huge, because in the end, that's what we're looking for, is that the parents and the families experience some change as a result in engaging with the material. Here's a wee quote. It is backed by the HSE, which is a recognised body. It is better than a blog because it was written by informed professionals and it's research-based. I've only used the NHS in the past, so it's great to have something that relates to the Irish HSE and health system. So that theme came out again and again in the interviews, is that it's Irish. Good. And people felt proud, not the users, but also a lot of the health service that we spoke to felt proud to have a resource that they could stand over and that was Irish. The next steps will be maximising accessibility for people challenged by language. So something from a method. I'm not going to talk a whole lot about methodology, and I've stopped myself, but there was some methodological interest in this evaluation, which is that we asked everybody, how would you rate it? And people gave ratings. But then we went out with a number of specific groups that may be more disadvantaged. So this includes single families, it included travellers, it included migrants. And we watched them use the website. We said, what would you like to know? And then we watched them use it and we tracked everything that they did and then we analysed that. And what was interesting is that they rated it highly, but when we tracked their use, they didn't actually get where they needed to go. And these groups, there's a lot of barriers to them obviously engaging with information online. But it did show us that is an area for more work and engagement with representative groups. And it taught us something interesting, that we can't always rely on data. We need to triangulate that where we can with looking at the real experience of people, because that gives us a whole other way to understand. And so in the recommendations, it's been a recommendation that is continued into the future. A big piece of development over the coming years will be enhancing the site so that parents can log their due date and get information specific to them and their own child's journey, as well as continuing with the very, very robust governance systems that will ensure that the site and then media around that responds to things that are emerging in the media, as well as new evidence as that comes online. So obviously there has to be a big system reach out to these 60 experts when needed and make sure that the site is adapting to changing circumstances and changing needs in the population. So parents also said, look, we want something online, but they also said, we still want a book. We like that. It's useful to us. So with that in mind, the program sought to create new books. And this would in part address the challenge that parents raised. 30% and just under 30% were saying they didn't receive enough information and they didn't receive clear and consistent messages. So it's a very clear need there that these books sought to address. 3 books were developed. The My Pregnancy book was new. The others drew on resources that existed in the HSE but substantially updated those. In total, there was around 600 pages. So again, a huge bit. And one of the quotes in the report you'll see says, well, we thought it might be a 75-page book. That's what we set out to do. But then we realized when we engaged with parents and we kept considering, what do people absolutely need to know? What is so important that we're going to print it and it's going to travel to homes all over the country? And with that very challenging editorial task, what we heard is that people were very happy with what landed in these books, and it is relevant, it is needed, it is accessible. And you can see there the numbers, I won't call those out, you can see the numbers there, they're being disseminated out across the country. So 82% of public health nurses are saying that the books are useful and are providing appropriate information. So that's, I think, a very clear sign that that editorial choice to create those 600 pages was a good one. Public health nurses are saying that they feel that, yes, the ultimate goal, that parents are more knowledgeable and confident, is being achieved through these guides, and that they have made parents' access to services better. So again, that's the final outcome that we're looking. And in terms of next steps, is an ongoing reprint so that parents always do have access to those. I'll let you read that quote yourselves. The one that stands out for me is we have one unified national resource. Again, coming back to that idea that we need one way of doing it, and it has to be the good practice way. So the new My Child Health Training Program. So previous to My Child, everybody will be aware that training was often delivered regionally and based on the priorities and resources in the region, which meant that there was a difference in terms of what people received and how often they had access to training, and indeed what that training was. So as part of this, there was a lot of talking to staff as well as to parents. And there was a sense that, yes, that needed to be addressed through one national program. A competency matrix was developed, and then a review of training approaches was also undertaken. Out of that came the decision to use a blended learning approach, which was predominantly online with some face-to-face training. 24 new or revised in-person trainings were done. So some of those are half an hour, some of those are a full day. And what we heard again is a real transition through the process. So at the beginning, there was quite a bit of nervousness around the notion of blended learning, and that there would be too much casualties from that, in the sense that people wouldn't have networking, they wouldn't be able to take the learning on board. And those were greatly reduced throughout people actually experiencing that training and engaging in the training. Not to say that some programs don't require mentoring or supports in place, but people were very, very open and very supportive of the blended learning approach. It was seen as accessible. People could do it in a variety of times, fitted around their very, very, very large workloads, and it ensured a common standard across the country. I'm not going to name all of the training, obviously, but there was breastfeeding, development assessment, behavioural sleep difficulties, growth monitoring, nutrition, child health safety, and some of the 11 goals are enshrined within this. Was around, especially the child health and the breastfeeding were goals that brought that work, some of the initial thinking to life. The other big bit that was really important was infant mental health. So this was a reasonably new idea in a formalised way within the HSE, although of course lots of practitioners would have been very well aware of what's coming out from research and the importance of this of this kind of new thinking and new research. But the program very conscientiously decided what are the key messages that everybody needs to have, and how can we integrate this into all of the training programs and all of the resources. So that's something that really found its feet in the training program. And 90% of public health nurses are saying that the training increased their understanding of the evidence base, which underpins their work. And also, so there's another thing we asked, resulted in more informed referrals. We also asked, does it increase your clarity on roles and responsibilities? So that's a very high rating, and we can see that compared to the others, is that this training program was very well received. We heard a lot in the interviews that there had been a perception of an underinvestment in public health nursing staff, and that this really increased morale. The fact that there was such an investment, that it had been done with such an amount of consultation, people really said, look, it has increased motivation and morale, and it's improved our confidence and our pride in our own sector. Probably things that we don't look at as much, but are very, very important to a well-functioning team. And that came from a survey of 232 public health nurses. So I felt the training was excellent. I felt a lot more equipped after leaving there. The last time I had an update on child health development was about 10 years ago. Afterwards, I felt more confident going out and doing the assessments again. So the next steps here are to continue to work with third level training bodies to ensure that some of this good practice is embedded when people do their initial training. Maintain the program and develop coaching and mentoring supports. This is really important because, as you can see to the left there, one of the big findings, one of the huge challenges, and I'm sure this is nothing new, but it's important that it's recorded and said again and again, is that the child health workforce feels stretched to the limits. And so PHNs are saying we don't always have time to do some of these things. And this has informed as well an ongoing advocacy agenda and approach around the system as to how to address that. But one of the things in training is looking at the coaching and mentoring supports. Also, into the future is making some of this training available to a wider network of services who are working in child health to ensure integration across all services. And of course, this is particularly pertinent where it's online training. So National Standard Child Health Records. So a lot of the CHO areas had done a lot of work in developing their own records, which was a real positive to contribute to the development of a national one, but also a challenge because once you've done all of that investment, do you really want to change it? Not particularly. So it meant that process had to be extremely respectful to people's efforts and work to date, as well as really listening to all of these areas and making sure that the final record was considered and validated by all of these groups as being good practice, as being the best version of itself that it could be. What we're hearing from staff is this is particularly important when their caseload is moving between areas. And there's an enormous frustration that occurs when you've got different records with different information, you want information, you have to make a call back to the hospital because you're used to or you need certain information. So this is reducing that inefficient management, allowing PHNs to spend more time with parents. And so that was something that was noted as being what people expect to happen because they were very aware of the current challenges around having different records. So a big piece is that it will build foundations for a national unified electronic record, which of course is a huge undertaking. And so that's something that people are very excited about, they want to see happen, and they see this as being very foundational to that next step progression. The next one is a national standardised health assessment, which is the Ages and Stages questionnaire, or the ASQ3. So again, some areas had been using this, but the HSE did a big review, or the partners did a big review to say, well, what kind of assessments do we need? And the ASQ3 came out as being the best model for Ireland. It's an internationally recognised parent-led tool. Parents complete assessments at home, bring this to their appointment, and there's a collaboration, which again talks to the needs that parents were highlighting in terms of a collaborative approach with health professionals to their children's needs. So there was a big piece of work to do in this in terms of rolling out nationally, which included the development of national guidelines, the development of an e-learning module, and then a train the trainer course as well, and a toolkit and implementation guide, as well as the supports to make sure there's central supplies and that people aren't spending too much time actually getting all of that together. So to date, over 1,000 practitioners have completed the training, and then 179 trained the trainers. So that work is ongoing. There was a small slowdown due to engagements with the union around the piece of work, but that too has been ongoing and is resolved. So what are people saying? Overall, people agree that this is likely to improve child health outcomes in a very serious, very concrete manner. People are saying that the training, the supports that they gave really matched their level of knowledge, and 85% agreed it was relevant to their work. 65% felt more confident as a result of the training and had the skills to use the tool. And again, that highlights the next steps in the program and making sure that there's mentoring and coaching for those that need that little bit more support for implementing the tool in practice. Here's what some people said. There's a positive development and gives PHNs the tools to address things in a more open and consistent way while also supporting families. Now, everyone will be doing evidence-based assessments. Every child is getting the same evidence-based service, and that's a significant win. So again, in years to come, I imagine this will be considered just, well, we always did it this way. And this is, I think, when change really has meaning, is people are like, well, yeah, of course we did this. But it wasn't, of course, and that's what we're hearing from people. Without the nurture program, this wouldn't have happened in anywhere near the same pace. It would have happened, but not in the same pace, not with the same level of support and consistency as nurture program allowed this change to happen. So next steps will be a finalising agreement to implement the ASQ, providing refresher training to staff who have had that small delay between getting the training and actually implementing it. Future reviews to look at the onwards referral pathways. So obviously if this is pointing out more needs, there's a need to make sure that those next step pathways are effective and are accessible to children who need them, and then gathering consistent national data on childhood development, because this and the national record really do bring a whole lot more consistent data to the table that can further fuel policy and practice changes in the years to come. So we're almost there, guys. I want to talk now just a little bit about the systems changes that Nurture sought to create to embed these huge practice changes into the future and ensure that they're sustainable. And so we asked stakeholders, and again that was over 60 interviews that were 45 minutes long, so this was a lot of content. People were extremely critical, and so we asked people across the HSE and allied services, what do you think, has this happened? And 76% of those stakeholders saw the Nurture program as being innovative in its approach. So this is how it did its work. And again, implementation science was flagged there as a huge element of that, as well as the partnership and as was the consultation with parents. 72% stated that there was a medium to large level of improvement in relation to communications within the HSC. And again, that came down to staff being consulted with. It came down to the role of how media was being used and how communications had been brought in as a fundamental aspect of the plan. So over half in the next two agreed that the program's approach has increased collaboration among different HSE departments. And of course, this is the real payload, isn't it, if that can happen, because it's one of the biggest challenges in such a big and complex system. 58% agree that the approach has increased collaboration between the HSE and allied services, which is a significant benefit. So the vast majority stated that staff training has increased the understanding of the evidence base underpinning their work. And I almost want to pause on that, because it was what Nurture set out to do. And that was in no way assured that that would happen, because the evidence-based to our work, it's big and it's broad and it's research, and we don't always have time to read academic papers. We don't, as any practitioner, you don't have time to engage, especially public health nurses with their huge workload and other health professionals. They don't have time to engage with new academic information and what is best practice. So the fact that Nurture managed to cross that bridge and ensure that people had access to that information that was relevant to their work in the way that they needed, in a way that was accessible and able to be absorbed, I think is a very significant achievement of the program, according to those we asked. The program supported early identification of health and maternal health needs, and it was slightly higher for child needs rather than maternal needs, which is understandable given the very clear focus on childhood assessment. Over 80% stated that there was a medium to large change in how public information on child health is developed and reviewed, and of course that comes a lot down to the resources in the website. It is a big change in the way that we create content aimed at the public. Now we look at all of the people who need to review a piece of information, maybe several experts, as well as communications expertise and the importance of design. The Nurture program has had a big impact on those areas. I think that quote really speaks to a lot of what was done in changing the way that information is designed, planned, reviewed again. I'm not going to do it 12 times, but you get the point. And then finally given to the public in a way that is accessible and that meets their needs and what they asked for very clearly. Usually people say we submit data and we don't see it. Now staff submit data on breastfeeding and they get to see their local rates as compared to others. This was done in 2018. People can see if they're approving, so that is important. I chose that quote because it reflects another theme that maybe wasn't picked up in other aspects of the presentation, and that what Nurture is doing is collecting and allowing for national data, and that's vital, especially when, in coherence with the Nurture program's philosophy about engaging and connecting with staff, it's being given back to staff in a way that has meaning and that they can use to develop their own services. Key recommendations. So these are in your report. I'm only going to touch on these lightly, and these are just the headlines. You can see there's a lot of detailed information in them. All of these ones here are about maintaining what's done and looking at some of those next steps that I spoke to. A lot of it is about bringing it to that next level in terms of parental engagement, in terms of integration with other departments, reviewing and making sure that the goals are maintained through the next phase of implementation. And important in number 5 there, in order to do that, it's important to adequately resource the National Healthy Childhood Program so that it can fulfill this role. So that is very, very clear, and it was lovely to hear Paul talking about that message has been heard and that this program is appreciated, and that all of that effort of engagement across the HSE has borne fruits in the sense that this is considered essential. There's work engaging around Slauncher care and big systems changes in terms of public health nurse resource allocation model. And that very much speaks to some of those challenges, the big challenges that did come up in the evaluation. And to look at the referral pathways onwards. So if the HSE is doing standardised assessments, is there some sort of standardisation in terms of access to assessments and further supports? And then we spoke about the electronic health record and the importance of that going forward. A lot of what happens within the health service focuses on the acute. So prevention and early intervention don't always get the same consideration. Nurture has helped push this. This is largely because of the investment of fundings to support the program and because we have external parties who are ensuring accountability and delivery of the program. So I want to end on that note and really saying that this has done something much bigger, according to you guys. This is what you said, is that this has put prevention and early identification need on the table in a way that for many years people wanted but found it very hard for the system, which is so finely attuned to the needs of acute health, could hear. And I think having Paul here say that exact same thing really does frame this evaluation. That came about because of the partnership, because of the very aligned view which people spent so much energy on creating as to what needed to happen. My last point is that people kept saying this is the foundation, and I think it's a nice metaphor because what you're looking at here is the foundation for children, is that those first 0 to 3 years being the foundation of a happy and healthy life. Just like Nurture itself has laid the foundation for what is an extremely effective and evidence-based health service. So I think let's end in a round of applause for yourselves and for the enormous work that was done and for what the evaluation has shown, which is that has, to a very high degree, delivered the returns, and there is very clear steps that have been endorsed throughout the health system on how the system can continue to develop and make sure that those foundations bear fruit. So congratulations.